Welcome back to the deep dive. Today we are taking a rapid but really rigorous shortcut into some of the most complex abdominal pathology you're going to face in clinical care.
We're talking about the interconnected world of biliary and pancreatic disorders.
Exactly. We're synthesizing all that dense, high-yield clinical knowledge from a core MedSurg chapter that's dedicated to these structures.
Our mission here is to move past just the textbook definitions and get right into the clinical reality.
Yeah, because these disorders, gallbladder stones, inflammation, pancreatic dysfunction, they're incredibly common.
And they often present as true surgical or, medical emergencies.
Yeah.
So we need to quickly establish the anatomy, understand the mechanism of disease, and I think most importantly, provide you with the essential nursing framework.
That framework is everything for pre-op, post-op, and critical care management.
Right.
So before we dive into the plumbing itself, let's define a few terms that are going to be critical reference points throughout this deep dive. Because in this area of the body, confusing two terms can completely change a patient's prognosis.
Okay, let's start with the gallbladder problem. You'll hear two terms constantly. Cholelithiasis.
Right.
That's simply the presence of stones, calculi in the gallbladder.
Okay, so just the stones.
Just the stones. But then you have cholecystitis. That is the inflammation of the gallbladder wall itself.
Got it.
And over 90% of the time, that inflammation is caused by the stones blocking the flow.
Yeah.
But you have to know the difference between the stone and the body's reaction to it.
Stones versus the resulting fire. Makes sense. Okay, moving to the pancreas. The immediate marker of trouble is enzyme activation. So which three digestive heavy hitters are we talking about here?
We're talking about amylase, lipase, and trypsin.
The big three?
Yep. Amylase breaks down carbohydrates, lipase tackles fats, and trypsin is for proteins. When the pancreas is injured, these enzymes can activate prematurely right inside the organ and then leak into the blood.
And that's what causes those dramatic spikes we look for in the lab.
That's exactly it.
Okay, what about the master switch? The thing that tells the gallbladder to squeeze and the pancreas to secrete its juices.
That's cholecystokinin, or CCK. It's the major hormone stimulus. When fatty or protein-rich food hits the duodenum, CCK causes two things to happen at the same time: a really strong gallbladder contraction and the relaxation of the Sphincter of Oddi.
Which opens the valve to the small intestine.
Right, it opens the gate.
We're also going to hear about two major high-tech procedures used to diagnose and treat problems in the ducts: ERCP and EUS.
So ERCP is endoscopic retrograde cholangiopancreatography. It's a mouthful.
It is.
It's basically fiber optic visualization of the biliary system from the inside, and it's often used to actually retrieve stones.
And EUS.
EUS is endoscopic ultrasound. It uses an ultrasound probe on the end of an endoscope. This gives you ultra-high-resolution imaging and lets you do targeted biopsies of the pancreas and ducts. It's incredibly precise.
And finally, a term that tells us digestion has failed completely: steatorrhea.
Yeah, that is the telltale sign of malabsorption. It means the patient is passing stools that are frothy, really foul-smelling, and have a high fat content.
So it's the clearest clinical indicator that the necessary bile or pancreatic juice just isn't reaching the intestine to break down those fats.
Exactly. It's a sign of major functional failure.
Okay, let's unpack the essential anatomy and physiology that dictates all of these disorders. We'll start with the gallbladder, the concentrating depot. We know it's small, but what does its structure actually allow it to do?
Well, it's surprisingly compact. It's a pear-shaped sac, and it only holds about 30 to 50 milliliters of bile.
That's not much at all.
No. And it connects to the main duct system through the cystic duct. But its primary structural importance is its ability to concentrate that bile.
And how concentrated are we talking? How much thicker does it get?
Dramatically so. So between meals, the common bile duct is closed off by the Sphincter of Oddi. The bile backs up into the gallbladder, and through water absorption across the walls, it can become 5 to 10 times thicker, more concentrated than the bile first produced by the liver.
So it's primed for maximum fat emulsifying power.
Precisely.
Now, when that concentrated bile is released, its components are essential to know because they determine the types of gallstones we see. We're talking water, electrolytes, lecithin, fatty acids, bilirubin, and bile salts. The circulation of those bile salts is one of the most efficient systems in the body, isn't it?
Oh, absolutely. That's the enterohepatic circulation. The bile salts emulsify fats in the small intestine, and then over 95% of those salts are reabsorbed in the distal ileum.
And sent back to the liver?
Yep. Returned to the liver via the portal blood and just recycled. It's a really high volume, low waste loop.
So if that system is so efficient, What are the first clinical dominoes to fall when a stone completely blocks that bile flow,
The clinical signs are directly related to the fate of bilirubin.
which is a byproduct of red blood cell breakdown?
Right. Normally, bilirubin is processed by the liver, mixed with bile, and sent to the intestines to be converted into urobilinogen.
Which gives stool its brown color.
Exactly. But if that path is blocked, the bile and bilirubin are forced back into the bloodstream.
Which gives us that classic clinical triad.
Precisely. First, the blood level of bilirubin spikes, causing jaundice, the yellowing of the skin and eyes.
Okay, number one.
Second, because that bilirubin isn't reaching the intestine, the stool loses its color and becomes clay-colored or grayish.
Right.
And third, the kidneys desperately try to excrete all these excess circulating pigments, which leads to dark, tea-colored urine.
Recognizing that triad is absolutely central to diagnosing biliary obstruction.
It's a flashing red light.
Now let's pivot to the pancreas, our dual function regulator. Focusing first on the exocrine side, its digestive powerhouse role.
The exocrine function is purely digestive. It secretes those enzymes, amylase, lipase, trypsin, plus a huge volume of highly alkaline fluid.
Rich in sodium bicarbonate.
Yes, and that's critical. This alkaline fluid, which can be 1,500 to 3,000 millilevels a day, neutralizes the highly acidic stuff coming from the stomach.
The chyme.
Right. It creates a pH-appropriate environment so the enzymes can actually work.
And those secretions are regulated by duodenal hormones, secretin for the bicarbonate, and CCK for the enzymes.
Okay, so moving to the endocrine side, which manages glucose metabolism.
That's the islets of Langerhans. You have the beta cells making insulin, which lowers blood glucose.
And promotes energy storage.
Right. Then you have the alpha cells making glucagon, which raises blood glucose by breaking down liver glycogen.
And the third one?
And the delta cells, which make somatostatin. It has a kind of hypoglycemic effect by interfering with glucagon and growth hormone release. It's a really intricate feedback system.
Before we move on, what subtle but important gerontologic considerations do we need to remember about the aging pancreas?
Well, after about age 70, although the size doesn't change much, there's an increase in fibrous and fatty material and a decrease in function.
So what does that mean clinically? The critical factor is a reduced rate of enzyme secretion, amylase, lipase, trypsin, and less bicarbonate output. Clinically, this impairs fat and calcium absorption.
So what's the takeaway for us?
It means we have to be really cautious when we interpret enzyme tests in older adults, and our dietary counseling has to focus specifically on compensating for this impaired absorption.
Now that we've mapped the plumbing, let's explore what happens when the pipes get clogged or inflamed, starting with the most common problems: gallstones and the inflammation they cause.
Cholecystokinin, the inflammation, causes the hallmark signs: pain, tenderness, and rigidity in the upper right abdomen.
Right.
The pain often radiates classically to the midsternal area or the right shoulder, and it's sometimes accompanied by nausea and vomiting.
And if it progresses quickly.
The gallbladder can fill with purulent fluid, which we call an empyema.
Over 90% of these acute cholecystitis cases are calculus caused by stones. It sounds like a severe chemical self-attack.
It is. The stone obstructs the cystic duct, preventing bile outflow. This stasis causes chemical irritation and autolysis.
The bile digests the gallbladder wall itself.
Exactly. Then you get edema and swelling, which compromises the vascular supply. That can quickly lead to gangrene or even perforation.
And bacteria play a role too, right?
They do, but they're usually secondary invaders, not the primary cause. Bacteria like E. coli or Klebsiella often move in afterward, but the initial problem is the chemical irritation.
What about the rare but really serious cases of a calculus cholecystitis inflammation without stones?
You often see these in the sickest patients, people recovering from major trauma, burns, massive surgery, or those who've had multiple transfusions.
And what's the theory there?
It's thought that fluid and electrolyte shifts, altered blood flow to the gut, and increased bile viscosity all lead to stasis and inflammation. Diagnostically, it's tricky because the patient is usually already critically ill, so finding the source of the inflammation is tough.
Turning to cholelithiasis, the stones themselves, we noted they are far more prevalent in women, especially over age 50. Let's look at the two main stone types.
The vast majority, about 75% in the U.S., are cholesterol stones. And this is really a functional disorder.
What do you mean by that?
Well, cholesterol needs bile salts and lecithin to stay soluble in bile. If the liver synthesizes less bile acid and more cholesterol, the bile becomes supersaturated.
And the cholesterol precipitates out.
Exactly. It falls out of solution and forms stones.
Okay, and the less common type pigment stones.
Those account for about 10 to 25% of cases. They're formed from precipitated, unconjugated bilirubin pigments,
And they're associated with.
conditions that cause high red blood cell turnover like cirrhosis or hemolysis or chronic biliary tract infections. Clinically, this distinction is huge because pigment stones cannot be dissolved with medication. They have to be surgically removed.
For the listener, let's revisit the classic risk factors for cholesterol stones. I remember an acronym for this.
The F's. It's a classic nursing mnemonic. Female, 40 or older, fat meaning obesity, which increases cholesterol secretion, and fertile, so multiparous status.
Are there others beyond those?
Oh yeah. Rapid weight loss, counterintuitively, significantly raises the risk because of changes in bile concentration. Also diabetes, ileal disease affecting bile salt reabsorption, and high-dose estrogen therapy.
Clinically, stones can be silent, but when they act up, the symptom of biliary colic is infamous.
This is that excruciating upper right abdominal pain, often radiating to the back or shoulder, associated with severe nausea and vomiting.
And what causes it?
It's caused when the gallbladder contracts violently against a stone that's lodged in the cystic duct. It typically happens several hours after a heavy, fatty meal that triggered that CCK release.
Let's address the pain management myth here. We know historically there was a fear of using morphine for biliary colic. Is that still best practice, or is pain relief the greater priority today?
This is a great point for a deep dive. Traditionally, morphine was avoided because it can cause spasm of the Sphincter of Oddi, and the theory was that could worsen the obstruction.
Right.
However, current evidence suggests that adequate pain relief is the primary priority.
So what are we using?
Parenteral opioids, including morphine, fentanyl, or hydromorphone, are often the preferred agents for acute pain management. Ensuring the patient is comfortable and minimizing restlessness is paramount.
So even though there might be some sphincter activity, the need for pain control just outweighs that risk.
It's considered more critical, yes.
Okay, so if that obstruction moves down to the common bile duct and persists, we already discussed the jaundice dark urine clay stool triad. But what functional complication results from the lack of fat digestion?
The immediate functional disaster is the malabsorption of fat-soluble vitamins, A, D, E, and K.
And the most critical one there is vitamin K.
Absolutely. Because vitamin K is essential for synthesizing clotting factors, a deficiency can lead to significant bleeding tendencies. The nurse has to be assessing the patient for signs of easy bruising or prolonged bleeding times.
Let's move to assessment and diagnostics.
Yeah.
As bedside nurses, our role here is not just, following orders, but ensuring patient safety and comprehension before, during, and after these complex procedures.
That's right. Before any test, we are the primary educators. We explain the prep, the expected outcome, and the risks. During the test, we monitor for complications.
In post-test, we integrate the findings to understand the disease progression.
Exactly.
So what remains the gold standard non-invasive diagnostic tool for gallstones?
Ultrasonography. It's rapid, it's accurate, and it involves no radiation exposure.
What's the prep for that?
The patient just has to fast overnight to ensure the gallbladder is distended. It detects stones in the gallbladder or a dilated common bile duct with really high accuracy.
And if ultrasound is inconclusive, particularly if we suspect acute inflammation without stones, that calculus cholecystitis, we turn to a more active imaging test.
That would be radionuclide imaging or a HIDA scan. We inject an IV radioactive agent that the liver excretes into the biliary tract.
And what are you looking for?
If the tracer doesn't enter the gallbladder, it indicates an obstruction. It's really the key test for those ambiguous inflammation cases.
Okay, moving to the heavy hitters. ERCP. This is a crucial procedure because it's both diagnostic and therapeutic.
Right. ERCP allows direct visualization of the entire ductal system. The hepatic, cystic, and pancreatic ducts via an endoscope pass through the stomach.
But its primary use has shifted, hasn't it?
It has. While it helps in diagnosis, its primary modern use is therapeutic. It's used for removing confirmed stones from the common bile duct, often using a little basket or a balloon.
That sounds like a heavy procedure. What is the single most critical and maybe most overlooked post-ERCP complication that a floor nurse must watch for?
The most dangerous complication is iatrogenic pancreatitis.
Caused by the procedure itself?
Yes, caused by irritation or trauma to the pancreatic duct during instrumentation. It's also vital to watch for signs of perforation or bleeding. The nursing implications are strict. NPO before, IV sedation, or MAC during.
And then afterward.
Post-procedure vigilance. You're looking for signs of sepsis, peritonitis, or escalating abdominal pain, which could signal perforation or the onset of pancreatitis.
The source also mentions percutaneous transhepatic cholangiography, or PTC.
PTC is largely historical for diagnosis. It's been replaced by ERCP and MRCP.
Mm.
It involves injecting dye directly into the biliary tract through the skin, and it's typically reserved for patients who can't safely undergo ERCP due to prior complex surgeries.
So it's very invasive.
Very. And because of the high risk of infection in these obstructed systems, broad-spectrum antibiotics and close monitoring for bleeding and sepsis are absolute musts.
Okay, now we move to management. Whether it's medical or surgical, the goal is to resolve the acute episode and remove the offending cause. In an acute attack, what's the immediate supportive treatment plan before surgery is even considered?
About 80% of patients will achieve remission conservatively first. So that means rest, IV fluids to maintain hydration,
Right.
NG suction for severe vomiting or distension, analgesia, and antibiotics. Surgery is usually delayed until the acute inflammatory symptoms subside, which can take a few days.
And the diet required during this acute phase is specific to avoid stimulating the gallbladder.
Immediately, we limit fat intake severely. We're talking low-fat liquids, advancing slowly to cooked fruits, rice, lean meats, and simple carbs.
So the teaching point here is what not to eat.
Absolutely. Avoid eggs, cream, pork, fried foods, rich dressings, gas-forming vegetables, and alcohol. Any fatty meal will trigger that CCK release and a painful spasm.
What about dissolving the stones pharmacologically dissolution therapy? We hear about UDCA or ursodeoxycholic acid. What are its limitations?
Well, UDCA and a similar drug, CDCA, work by inhibiting cholesterol synthesis. This desaturates the bile and allows small cholesterol stones to dissolve.
But there are some major limitations.
Severe limitations. It only works on small, radiolucent cholesterol stones. It requires continuous therapy for 6 to 12 months, has a low success rate, and a really high recurrence rate once you stop it.
So who is it for?
It's really only used for patients who are not surgical candidates for one reason or another.
The source also mentions other non-surgical removal methods which are becoming rarer. Can you briefly touch on stone removal by instrumentation and lithotripsy?
Sure. Stone removal via instrumentation, often through a T-tube tract left after an open surgery, uses baskets to kind of fish out stones lodged in the common bile duct.
Lithotripsy.
Lithotripsy uses either internal laser probes or external shock waves, ESWL, to fragment the stones. Both methods have largely been replaced
Why is that?
because the standard of care, laparoscopic cholecystectomy, is just much more definitive and less risky overall.
That brings us to surgical management and the gold standard. Laparoscopic cholecystectomy, or LC.
LC is the standard procedure for 80 to 90% of symptomatic patients. Under general anesthesia, the abdominal cavity is insufflated with carbon dioxide, a pneumoperitoneum, to create a working space. The surgeon then uses 4 small half-inch incisions to clip the duct and artery and remove the gallbladder.
And the advantages of LC are transformative for the patient experience.
It's a massive change. No paralytic ileus, minimal pain, often a same-day discharge or maybe a one-night stay, and a rapid return to full activity within about a week.
That's incredible compared to the old way.
Right, compared to the traditional open cholecystectomy, which requires a lengthy subcostal incision, a long recovery, and a much greater risk of pulmonary complications.
We have to anchor the most crucial post-op teaching point regarding the LC, that seemingly misplaced pain.
That's the CO2 pain. The gas used to insufflate the abdomen can irritate the phrenic nerve as it migrates up toward the diaphragm, causing referred pain in the right shoulder or scapula.
So what do we tell the patient to do about it?
We instruct them to use a heating pad for 15 to 20 minutes hourly to help the gas dissipate, and to ambulate, because movement also helps clear that CO2.
If the patient is too sick for LC, or if the anatomy is complex, a traditional open procedure might be necessary.
Yes, or one of the specialized high-risk options. For instance, a surgical cholecystostomy opening the gallbladder to remove stones and drain it is reserved for critically ill patients with severe infections.
Patients who are too unstable for a full cholecystectomy.
Exactly. But it carries a high mortality rate because of the underlying severe disease.
And what about the non-surgical decompression option for those same high-risk patients?
That would be a percutaneous cholecystostomy. A catheter is inserted under imaging guidance to decompress the gallbladder. It provides almost immediate symptomatic relief for septic patients who just can't tolerate surgery.
EUS-guided drainage is also used now, right?
Yes, very effectively in comparable situations.
Finally, let's revisit the older adult patient in surgery. What's different about their presentation?
Their presentation is often atypical. They might lack the classic fever, pain, and jaundice.
So what might the nurse see instead?
You might see signs of impending septic shock, oliguria, hypotension, mental status changes, tachycardia, and tachypnea. While elective LC is well tolerated, emergency surgery in this population carries a very high mortality risk. It demands intense monitoring and vigilance.
Okay, now we apply the nursing process to gallbladder surgery. This is where we bridge the procedure to practical patient care. Why is the respiratory assessment such a massive priority when the surgical field is the abdomen?
That's a great question. If the patient has a traditional large abdominal incision, which runs high on the abdomen, they will naturally splint.
They avoid taking deep breaths because it hurts.
Exactly. And that significantly impairs lung excursion and puts them at extremely high risk for pulmonary complications like atelectasis and pneumonia.
Especially if they're obese or have pre-existing lung issues.
Right, so the pre-op assessment has to nail down their smoking history and baseline breath sounds.
Post-op, our primary goal is pain relief, but for a greater purpose than just comfort.
Absolutely. We need to administer analgesics aggressively because we know if they're in pain, they will not breathe, cough, or move. The nurse has to liberally medicate the patient to facilitate those essential activities.
Turning, deep breathing, coughing, incentive spirometry, and early ambulation.
All of it. And we teach them to split the incision with a pillow or a binder during these maneuvers.
Speaking of respiratory status, what's the core intervention routine?
Consistent, hourly deep breathing, coughing, and incentive spirometry use, along with maintaining a semi-Fowler position to aid diaphragm movement. Early ambulation is non-negotiable.
Okay, let's discuss the impaired skin integrity diagnosis, which is relevant if the patient has a drain or a T-tube inserted into the common bile duct. How do we manage that drainage?
First, the drain must be connected to a receptacle and fastened securely below the level of the common duct to ensure gravity drainage. The nurse has to constantly monitor for signs of obstruction or leakage, checking for jaundice, RUQ pain, and any unexpected drainage.
And what about the specific T-tube management protocol?
We measure and record the amount, color, and character of the drainage daily. To help the patient digest their food, we might clamp the T-tube for an hour before and after meals, which directs bile into the duodenum.
And crucially, protecting the skin.
Yes, the skin must be protected from the corrosive bile drainage. That requires frequent dressing changes, applications of protective barrier creams, and maybe even a consultation with the WOC nurse. The T-tube is typically removed within 3 weeks.
What about nutritional improvement post-surgery? Is the patient destined for a low-fat diet forever, or is that a temporary measure?
That's a common patient myth we have to debunk. Initially, the diet is low-fat, high-carb, and high-protein.
But the fat restriction is usually temporary.
Right, usually only lasts 4 to 6 weeks. By then, the biliary ducts have typically dilated enough to accommodate the full volume of bile needed for normal fat digestion, and the patient can return to a normal diet.
And they don't have that fat intolerance they had before.
Correct.
Since most patients go home so quickly after an LC, promoting that transitional care is vital. What are the non-negotiable discharge instructions regarding symptoms and activity?
We need to use the teach-back method to ensure they really understand this. We're talking about chart 44 too.
So what are the key points?
For activity, light walking immediately, but avoid lifting anything heavier than 5 pounds for 1 week. For pain, use that heating pad for the referred CO2 shoulder pain.
What about wound care?
Check the puncture sites daily for infection and let those steri strips fall off on their own.
And the red flags, the reasons to call the doctor.
They have to report a fever over 37.7 Celsius or 100 Fahrenheit for 2 consecutive days. Also persistent vomiting, escalating abdominal pain, or any signs of wound infection redness, heat, drainage.
Right.
We also warn them that they might experience loose, frequent bowel movements at first, but that usually subsides over time.
Let's transition now to a disorder of much higher acuity, acute pancreatitis. What is the core definition of this illness beyond just inflammation?
It's the pathological process of autodigestion. The pancreas's protective mechanisms fail, and those potent exocrine enzymes, amylase, lipase, trypsin, activate prematurely within the pancreas itself.
So instead of digesting food, they begin digesting the pancreatic tissue.
Exactly. It effectively turns the organ into a necrotizing, inflamed soup.
The chapter classifies this into 2 main types based on severity.
Right. The majority of cases are interstitial edematous pancreatitis. This is characterized by diffuse swelling and inflammation that's confined to the gland. While the patient is severely ill, their function usually returns to normal within 6 months.
And the more dangerous type.
The minority, and the most dangerous, is necrotizing pancreatitis. This is where there is actual tissue death. This necrosis damages blood vessels, leading to bleeding and thrombosis, and it can quickly evolve into systemic complications.
Like organ failure, shock, and abscesses.
All of the above.
Who is most at risk for developing this severe necrotizing form?
Well, mortality increases sharply with age. While younger patients often handle local complications better, older adults have a much higher incidence of progressing to multiple organ dysfunction syndrome, or MODS.
So aggressive monitoring of their cardiovascular, respiratory, and renal status is essential.
Absolutely critical.
What accounts for 80% of acute pancreatitis cases? What are the two main culprits?
It's overwhelmingly gallstones and sustained alcohol abuse.
How do gallstones cause it?
They cause a mechanical obstruction and bile reflux at the ampulla of Oddi, which triggers that premature enzyme activation.
And alcohol.
Alcohol abuse is thought to directly damage the cells and cause protein hypersecretion, leading to protein plugs and chronic calculi that block the smaller ducts.
The classic clinical manifestation is severe abdominal pain. Describe that patient experience.
It is typically excruciating, relentless, and located in the mid-epigastric region, often radiating straight through to the back.
And when does it start?
Usually 24 to 48 hours after a heavy meal or significant alcohol intake. Crucially, it is unrelieved by antacids or even initial doses of opioids and is made worse by eating. The patient often assumes a fetal position or sits up and leans forward for minimal relief.
What associated signs indicate a catastrophic progression or internal bleeding?
We look for abdominal distension, guarding, and decreased peristalsis. The severe signs include hypotension and shock, which result from massive fluid shifts into the peritoneal cavity.
Leading to tachycardia, cyanosis, and cold, clammy skin.
Yes. And then you have the classic, if rare, bruising signs. Ecchymosis in the flank, that's Gray Turner sign, or around the umbilicus, which is Collins sign. Both indicate retroperitoneal bleeding.
And respiratory distress is also extremely common.
Very. The inflammation causes the diaphragm to elevate, and systemic inflammation leads to hypoxia, so they often need aggressive respiratory support.
To diagnose this, we look at labs. Which two enzymes are our gold standard?
Serum amylase and lipase. The diagnosis requires these levels to be elevated more than 3 times the upper limit of normal.
Is one preferred over the other?
Lipase is often preferred because it stays elevated for longer. Other correlating labs are elevated white blood cells, transient hyperglycemia, and the critical finding of hypocalcemia, which strongly correlates with disease severity.
To predict mortality early and guide resource allocation, the Ranson criteria are stressed. Instead of just listing all 10 values, what are the high-yield themes those criteria are measuring?
Ranson is really measuring the patient's capacity for systemic failure. Upon admission, we're measuring the inflammatory load, like a white count, over 16,000, and the degree of initial cell damage, like LDH and AST elevation.
Okay, so that's at admission. What about within 48 hours?
Within 48 hours, the most critical predictors relate to fluid shifts, metabolic derangement, and oxygenation failure.
Such as?
A sudden fall in hematocrit of more than 10% signifies massive fluid sequestration or bleeding. A critical drop in serum calcium, below 8, shows poor prognostic metabolic activity.
And the fluid retention.
Large fluid retention, over 6 liters, or a severe drop in PO2 below 60 indicate impending shock and pulmonary failure. If a patient meets more than 6 of those signs, the mortality rate just skyrockets toward 100%.
This highlights the need for intense intervention, moving us to management. We established that the gut must rest, so NPO is the rule. But how does that square with the need for immediate nutrition?
It creates a paradox, right? We have to inhibit the pancreas, but severe malnutrition sets in really quickly.
So what's the current best practice?
It overwhelmingly favors early enteral feeding, usually via a nasojejunal tube. This is preferred over total parenteral nutrition, or TPN, whenever possible.
Why is that?
Because enteral feeding safely prevents infectious complications and maintains the gut barrier function. TPN is really reserved for patients who truly cannot tolerate the enteral route.
What is the specific role of NG suction?
It is not used routinely to decrease pancreatic secretions. It's only indicated to decompress the stomach and relieve severe nausea, vomiting, painful abdominal distension, or paralytic ileus.
And since pain is relentless, what's the best strategy for control?
Aggressive parenteral opioid use, morphine or hydromorphone, often via a PCA pump. We have to ensure comfort and minimize restlessness, which stimulates the pancreas.
And that concern over the sphincter of Oddi spasm is secondary.
It is. It's secondary to the primary need for adequate pain relief.
If infection is suspected in the necrotic tissue, how is that managed?
Well, Prophylactic antibiotics are discouraged. Antibiotics are only used if a culture confirms an infection. If necrosis is present, the standard is the step-up approach.
What does that mean?
We start with the least invasive methods. Percutaneous or endoscopic catheter drainage to drain the infection. Surgery for debridement is a major procedure that's reserved only if those first-line interventions fail.
Let's pull the nursing priorities from the care plan in chart 44-4. Beyond pain control and NPO status, what are the top 3 non-negotiable interventions?
1. Respiratory vigilance, a semi-Fowler position, frequent position changes, and hourly pulmonary hygiene spirometry, deep breathing, to prevent atelectasis and hypoxemia.
Okay, number 1.
2. Meticulous fluid and electrolyte management, assessing INO, daily weights, skin turgor, and labs constantly. Promptly reporting a decreased BP or urine output is life-saving, as it signals hypovolemic shock.
And number 3.
Skin integrity protection. If drains are present, the patient is at extremely high risk for skin breakdown because the pancreatic enzymes are literally digesting their skin. We need continuous suction of the drainage tract and likely WOC nurse involvement.
Finally, home care for the survivor. What absolutely must be reinforced?
Strict lifestyle modification. They have to avoid heavy meals, high-fat foods, spicy items, coffee, and this is the big one, absolutely no alcohol.
And if alcohol was the cause?
Referral to Alcoholics Anonymous or equivalent resources is a critical nursing intervention because recurrence is deadly.
Let's move to section 8, covering the chronic destructive diseases of the pancreas, starting with chronic pancreatitis. This is a progressive disease distinct from those acute flares.
It is. It's characterized by the progressive destruction of the pancreas, which is replaced by fibrous tissue. This causes ductal obstruction and leads to a massive loss of function.
Oh, massive.
90% of exocrine function is typically lost before the classic symptoms of malabsorption even appear.
And the primary cause is also alcohol abuse in about 70 to 80% of cases, often in middle age. The symptoms are similar to acute, but the pain dynamic is different.
The pain is relentless. Recurring, severe upper abdominal and back pain, often requiring high doses of opioids. This creates a dual challenge, managing intractable pain while minimizing the severe risk of opioid dependence.
So the pain can be episodic or it can burn out.
Right. It may eventually decrease entirely, what's called burnout, as the gland is completely destroyed.
Weight loss is also rampant here.
Over 80% of patients experience it, largely because of anorexia or the fear that just eating will precipitate another painful attack.
And this leads directly to the defining sign of functional loss.
Steatorrhea, the late-stage malabsorption that results from having less than 10% of function remaining.
So management focuses heavily on minimizing dependency and replacing what's lost.
Exactly. Non-surgical management uses the WHO 3-step ladder for chronic pain, focusing on non-opioid strategies and adjuncts like celiac nerve blocks, yoga, and antidepressants. We rigorously enforce alcohol and smoking cessation.
And if the patient has resulting diabetes?
Treatment is intense, often requiring insulin, with constant teaching about the extreme danger of hypoglycemia if they consume alcohol.
And the replacement therapy?
Pancreatic enzyme replacement therapy, or PERIT, is essential for malabsorption and steatorrhea. It improves nutritional status, and it also reduces the painful stimulation caused by undigested food in the duodenum.
Surgery here is usually palliative, a pancreaticogynostomy or limited resections. It's aimed at pain relief and improving drainage, but still carries high risks due to the patient's generally poor health.
Right. We also need to remember pancreatic pseudocysts. These are walled-off fluid collections rich in amylase that form after acute pancreatitis.
So,
If they require external drainage, the nursing care is intensive because that enzymatic drainage is highly corrosive to the skin.
so again, continuous suction and vigilant skin protection.
It's a must.
And finally, the most sobering diagnosis: cancer of the pancreas. We noted the prognosis is grim, with a 5-year survival rate around 7%.
Yeah, it's the 4th or 5th leading cause of cancer death. Diagnosis is frequently late because the initial symptoms of vague, boring upper or mid-abdominal pain radiating to the back are easily ignored or misattributed.
So the classic triad of pain, jaundice, and weight loss only appears late.
Often only when the disease is already advanced, and sometimes diabetes can be an early, subtle sign.
How do we diagnose a tumor that is so difficult to find?
A spiral or helical CT is the most useful preoperative tool, followed by EUS for smaller tumors, or to perform fine needle biopsies. We use tumor markers like CA19-9 for monitoring progression, not for the primary diagnosis.
Since total excision is rare, treatment is often palliative, focusing on symptom management.
Chemotherapy and radiation are standard for metastatic disease. A major palliative intervention is inserting a biliary stent, often via ERCP, to relieve the severe jaundice and pruritus caused by the obstruction.
Given the poor prognosis, the nursing management shifts entirely to quality of life.
That's where the nursing focus on symptom clusters from chart 44 to 5 becomes vital. We manage pain with liberal opioids, often via PCA. We address skin care related to jaundice and cachexia. The nurse has to guide the patient and family through the distressing combinations of symptoms they will experience.
Providing anticipatory guidance and, when appropriate, facilitating a hospice referral.
Exactly.
The majority of tumors occur in the head of the pancreas, causing early obstruction of the common bile duct. This is where the massive surgery comes in, the Whipple's procedure.
The pancreatic duodenectomy, or Whipple, is one of the most extensive and complex operations in general surgery.
What does it involve?
It removes the gallbladder, the head of the pancreas, portions of the stomach, duodenum and jejunum, and the distal common bile duct. The remaining organs are then painstakingly reattached to the jejunum.
The immediate clinical challenge post-Whipple is enormous. You're essentially creating diabetes and malabsorption simultaneously.
You are. Post-op care is critical. These patients require ICU monitoring for major complications like hemorrhage, vascular collapse, and hepatorenal failure.
And the long-term challenge?
Lifelong management of the sequelae. Insulin-dependent diabetes from removing the beta cells, and a severe malabsorption syndrome requiring pancreatic enzyme replacement and fat-soluble vitamin supplementation.
The discharge education for a post-Whipple patient must be incredibly detailed.
Absolutely non-negotiable. It includes incision and drain care, symptom recognition of complications, a low-fat diet, enzyme replacement adherence, and managing their new diabetic status. The family requires immense emotional support given the procedure's gravity and the poor prognosis.
Let's briefly touch on the rare islet tumors, or NETs.
The two major types are insulinoma, which hypersecretes insulin, causing severe hypoglycemia, confusion, weakness, seizures. That's immediately relieved by glucose. The treatment is surgical removal. And ulcerogenic tumors, which cause Zollinger-Ellison syndrome by hypersecreting gastric acid. This leads to intractable peptic ulcers. While surgical excision is attempted, it's often managed with high-dose proton pump inhibitors.
What a detailed look into the management of these complex abdominal disorders. To recap, we've learned to spot the difference between the stone and the resulting inflammation and identified those clear signs of biliary obstruction, jaundice, dark urine, and the danger of vitamin K deficiency.
We also covered the urgency of acute pancreatitis, synthesizing the Ranson criteria into those critical signs of systemic failure and establishing the modern standard of care. NPO with early enteral feeding, aggressive pain management, and absolute vigilance for F&E imbalance and respiratory compromise.
And we closed with the sober reality of pancreatic cancer, where diagnosis is late, prognosis is poor, and major palliative surgeries like the Whipple procedure demand intense critical care focused on preventing hemorrhage and managing immediate, profound metabolic changes.
Things like insulin deficiency and malabsorption.
Right.
The synthesis of precise anatomical knowledge with a clear understanding of systemic compensatory mechanisms, especially the need for critical intervention in respiratory status and F&E balance, is really the fundamental nursing takeaway for effectively managing these high-acuity GI disorders.
So given that recurrence is a huge issue for chronic pancreatitis and gallstones, and the prognosis for pancreatic cancer hinges on early, almost accidental detection, here is our final thought for you to consider.
Okay.
If future diagnostics allowed for non-invasive, widespread screening, perhaps measuring enzyme levels or bile composition shifts years before symptoms appear, how would that shift the entire patient care model from managing acute crises to preventing them?
Thank you for joining us for this deep dive.
We hope you feel more than well informed.